So next is the appendiceal carcinoid. A 33-year-old male who underwent a lap appendectomy 2 weeks ago has been referred to your endocrine clinic. The histology report confirms an 18 millimeter carcinoid in the tip of the appendix. What is the carcinoid tumor? So carcinoid tumors are neuroendocrine tumors. The term now specifically applies to the tumors of the midgut, jejunal and proximal colon. They secrete serotonin and stain with chromogranin A and synaptophysin immunostatins. Appendix carcinoids are usually non-secretory, commonly picked up incidentally. How are they classified? They classified by different perspectives. Number one is site of origin, foregut, midgut, hindgut. Degree of differentiation, well-differentiated endocrine, non-functioning, really invasive. Then is the well-differentiated endocrine, functioning and often invasive. Then poorly differentiated endocrine, non-functioning and invasive, and mixed exocrine endocrine tumors. What is the differentiation classification based on? So it's on the histological appearance. It's a mitotic index, and then it's Ki67 proliferation index. So well-differentiated tumors have low mitosis, low proliferation index, and poorly differentiated tumors have high mitosis and high proliferation index. And then is the TNM classification of appendiceal carcinoids: T1 less than 2, T2 2 to 4, T3 more than 4, and T4 breaches the peritoneum and invades the adjacent structures. Does this patient need further treatment? No. He has been fully treated. The indications for further surgery are: size of the tumor is more than 2 cm, incomplete resection margin, serosal surface breach, invasion of mesoappendix by more than 3 mm, high proliferation index, and positive lymph nodes. This patient needs a completion right hemicolectomy. Small tumor in the base of appendix also require completion right hemicolectomy. They may represent colonic carcinoid tumor. How would you follow him up? So appendiceal carcinoids more than 1 cm should have 10-year follow-up. For those patients who needed a completion right hemicolectomy, I would request bloods 5-hydroxyindoleacetic acid, 5-HIAA, or chromogranin A scan, and 3 months at 3 months after section, and I will request CT scan, MRI, and octo scan. How would your management plan change if the histology report confirmed a goblet cell carcinoma? So this is a more malignant variant, also called as an atypical carcinoid. It does not express somatostatin receptors and cannot be visualized by an octodioid scan because it don't have receptors. There is a possibility of aggressive treatment spread in the mesoappendix and intraperitoneally. This patient needs completion, extended ileocolic and mesenteric resection, and may need chemotherapy. They have a less favorable survival, 60% 10-year survival rate. For aggressive tumors, cytoreductive surgery in the form of omentectomy, peritonectomy, and splenectomy should be offered. What is carcinoid syndrome? This occurs when the vasoactive substances produced by a tumor escape the hepatic degradation. It can be seen when GI carcinoids metastasize to the liver or primary carcinoids. In extraportal location, bronchial carcinoids, peritoneal infiltration. It occurs only in 5% of the carcinoids. Prominent symptoms include diarrhea and flushing, flared up with alcohol and chocolate. And other features include pellagra, telangiectasia, tricuspid regurgitation. Patient with carcinoid syndrome or midgut carcinoid with or without hepatic met should be considered for carcinoid heart disease screening using echocardiogram and measuring N-terminal pro-brain natriuretic peptide, NT-proBNP. Thank you.